Hello and welcome everyone to today's webinar, TBI Diagnostics. This webinar is hosted by Medical and Life Care Consulting Services, a case management and nurse consulting firm headquartered in Massachusetts. We're excited that you've joined us for this presentation. My name is Amanda Barnett and I will be the moderator for today's webinar. This webinar is anticipated to be about 50 minutes with an additional 10 minutes provided for questions and answers. Participant audio will be on mute throughout the webinar, and we ask the questions are submitted using the question and answer feature within the Zoom webinar dashboard. Post-webinar, we will share a link to where you can access an on-demand replay along with a link to a short survey. Please take a moment to complete the survey. Your feedback is valuable and helps us in the planning of our educational resources. We're excited to host today's webinar and look forward to an opportunity to partner with you. To kick us off, I'd like to introduce our host, Cynthia Bourbeau. Cynthia Bourbeau is president and founder of Medical and Life Care Consulting Services, a registered nurse, a certified rehabilitation nurse, a certified case manager, a certified nurse life care planner, legal nurse consultant, and a certified health professional life care planner. She has worked as a nursing professional for over 40 years and currently leads Medical and Life Care Consulting Services, a practice of professional nurse consultants and case managers who provide medical case management, medico-legal services, including life care planning, and ancillary professional nurse consulting services, as well as vocational expert witness services and case management. Cynthia founded Medical and Life Care Consulting Services in 2001 and is presently a member of the American Association of Nurse Life Care Planners and is a board member on the Universal Life Care Planner Certification Board. She is also an active member of the Association of Rehabilitation Nurses, the International Association of Rehab Partners, and the Case Management Society of America. At this time, I'll pass it to Cindy Bourbeau.
Thank you, Amanda. First, I'd like to share a little bit about the Injury Insight Program. This is a four-part webinar series that is designed to educate claims professionals, human resource professionals, and case managers on the rehabilitation and recovery process of injuries, illnesses, diagnoses, and treatments both common and uncommon within workers' compensation. The program allows claims professionals and industry stakeholders to have direct access to medical specialists to help you better understand the diagnoses, the road to recovery, and potential obstacles, and answer your toughest of questions. So get your questions ready. I'd like to, before I introduce Dr. Center, say thank you for doing this with us today. He came highly recommended, and I'm really looking forward to hearing his presentation. And this is this year's second Injury Insight session, TBI Diagnostics, and we're pleased to have Dr. Wesley Center here. He will guide us as he explores how neurofeedback, guided by quantitative EEG, facilitates recovery after traumatic brain injury. This session will highlight how quantitative EEG maps brain activity to identify areas that need targeted support, enabling customized recovery plans that enhance cognitive and emotional being. We will also examine the application of these tools in personal injury and legal cases, showing how advancements in brain health technology are making a measurable impact in recovery and rehabilitation. Dr. Wes Center is the president and clinical director of Brain and Behavior Associates and the chief science and technology officer for OCAT Neurotech, LLC. Dr. Center is licensed by the state of Texas as a licensed professional counselor and board-approved supervisor. He completed his undergraduate education at Howard Payne University in Brownwood, Texas, and then served on active duty in the U.S. Marine Corps for over 20 years. Retiring with the rank of major, and is a combat veteran. Dr. Center is a national certified counselor, a board certified fellow in neurofeedback, a BCIA approved mentor, a certified brain health coach, and a certified Amen method professional. Dr. Center has extensive experience in forensic quantitative EEG assessments, particularly in personal injury cases involving mild traumatic brain injuries and in criminal matters where quantitative EEG and other neuroimaging methods can be used in mitigation and post-conviction relief. Dr. Center also has extensive clinical experience working in outpatient and hospital-based psychiatric and substance abuse treatment facilities. He is also involved in supervising and mentoring beginning counselors, neurotherapists, brain health coaches, and professionals looking to add neuromodulation interventions to their existing practices. Dr. Center is a member of the Society for Brain Mapping and Therapeutics, the International Society for Neuroregulation and Research, and the Biofeedback Certification International Alliance. And with this, I'll turn this over to Dr. Center, saying thank you again. Go ahead and take it away, Dr. Center.
Great, thank you. So I'm not going to read the slides to you because I assume everybody here has, passed the 12th grade reading level. So I always get irritated when people read slides to me. So I'm not going to do that to you. And so the things that are important are on the slide, but I'm kind of fill in some of the details around the slides. So we're going to talk about several different aspects of traumatic brain injury, diagnosis, assessment, and treatment in particular. And then we'll be able to discuss toward the end, actually, what takeaways that you as in the life care planning field are going to want to take away from what I've got to give you today. So just at a glance, as we look at traumatic brain injury from a claims and case management perspective, based on the current guidance for TBIs, a mild traumatic brain injury is by definition one in which the neuroimaging is negative. In emergency departments, the most common used method for neuroimaging is computed tomography or CT. Every great once in a while, you'll see an order for an MRI, and it depends on what the protocols in-house are for neuroimaging. But part of the issue related to that is many people present to the emergency department or are on the scene with more soft tissue complaints than they do head injury complaints. And so many times the soft tissue gets addressed, but because it's the most acute and most painful aspect of the injury, and most all of these that we're talking about are either going to be from motor vehicle accidents or from falls. And then the next common category is going to be sports-related head injuries. But those are generally going to present as a head injury. In falls and in motor vehicle accidents, presentation is largely going to be soft tissue. And so that's what's going to get addressed by the medical community, are the things that the patient is complaining about as causing them the most pain. What is often unaddressed are the neurocognitive and memory symptoms that are associated with traumatic brain injury in the acute phase. So we're talking about that first 36 hours after the injury. That's the acute phase, and when it's most critical. We need to have some objective findings. And unfortunately, what's done mostly in emergency department settings, even in primary care settings, is very subjective. Questionnaires, how you doing, how you're feeling, using subjective units of distress as the measure of the extent and nature of the injury. And unfortunately, those are not objective. So we need to be able to have reproducible, replicable, quantifiable assessment measures, because this can significantly alter the path that we're taking in terms of not only diagnosis and the rest of the assessment, but also in those initial aspects of how we're going to treat this. And then one of the things that we do when we're assessing head injury is focus on function, and particularly functional deficits. Do we have a deficit in learning? Do we have a deficit with visual motor skills and tasks? Do we have a deficit in terms of attention? All of these things are really closely associated with concussion, post-concussion sequelae, but are not normally identified in the emergency department or primary care setting. So when you understand these principles of just because you have normal imaging doesn't mean you don't have an injury. It just means that that particular imaging method wasn't sensitive to or specific to TBIs. We need to have objective standards of measure, and we need to focus on what the functional deficits are, not merely feeling states. So that initial 24 to 48 hours, according to the acute mild traumatic brain injury standard of care that was published in 25, that initial 24 to 48 hours implement rest protocols, or what we call relative rest protocols. So we don't want total rest, because that can actually be less helpful than a gradual return to a functional daily activity schedule. We don't want strict bed rest, because that creates other problems. And we want to have minimal activities that allow for us to be edging up to the level of discomfort of the patient, because that helps us to understand how significant the actual injury is. Within 3 to 7 days, we want to have that gradual symptom-limited return to cognitive and physical activity, like return to work, return to school, return to moderate levels of exercise. So we're talking about walking, not running. We're no weightlifting during that period of time. But we want to have a gradual return to activity. And again, we do want to look at how are they responding to the return to activity, and then adjust intensity based on, again, subjective units of complaint or discomfort. So it's extremely important that we do have a gradual return within 72 hours of the insult. And then when we go beyond 2 weeks, and the reason we say 2 weeks is because all the physiological healing that's going to take place is going to happen within minutes of the actual insult to about 2 weeks later. And so all the neuronal healing, all the microglia coming out and cleaning up the damaged axons and diffuse axonal injury, for example, all of the cleaning up of the debris of dead cells, all that's going to happen within the first 2 weeks. And so whatever physiological healing is going to take place is going to largely be done at the end of 2 weeks. That's that kind of critical window. And again, we're talking about mild to moderate injuries, not the more severe. So why rest only can be a problem is that inactivity allows for some things to happen that we don't want to happen during that post-acute recovery phase. So it can make mood disorders worse, irritability can be worse, angry outbursts can be exacerbated by excessive rest. It can mess with the circadian sleep cycle, and it can lead to overall physical deterioration from excessive rest. The other problem it can cause, and I'm going to talk about this more later, is it can cause the body not to respond to the glutamate cascade that causes excitotoxicity. So glutamate is an excitatory neurotransmitter, and it's released in bucket loads in the immediate aftermath of an injury. And it has an actual neuroadaptive reason for doing so. But if that cascade is not countered by an increase of calcium activities to block the entrance of glutamate into the axon terminals, it can lead to a thing we call brain rot, which is the actual death of the axon and eventual death of the cell body. So what we want to do is we want to address that excitotoxic response by an appropriate level of counter-inflammatory responses, and that's actually done through activity. The other thing is we want to increase cerebral blood flow and oxygenation, and you actually decrease cerebral blood flow and oxygenation with excessive rest. So again, this causes this negative spiral of inactivity, and it becomes a self-perpetuating loop that can become difficult to break. So again, we do not want to see excessive rest or complete inactivity, even within the first day or two of the injury. So again, in that first 72 hours, that glutamate, excitotoxic response causes this neurometabolic cascade that results in cell death. So calcium and sodium should create this massive energy demand, where at the same time, this excitotoxic glutamate is also causing this huge demand. and it causes the neurons to depolarize in the big fields, the large fields of neuron. And again, the brain activity actions are groups of neurons, not individual neurons. No individual neuron can do anything. We've got to have at least 100,000 to 1 million of them acting together, firing together to create what's called an action potential. And without these massive field firings, nothing happens in the brain. Well, when you get these massive dumps of glutamate, which causes a massive depolarization of the neurons, they become excitatory. The brain's primary activity is inhibitory. So you have this kind of counterproductive excess excitation at the very time we need for it to be calm. And not only does it produce excitation, it also produces neuroinflammation. And again, anywhere in the body you have excessive and prolonged inflammation, it is a bad thing. So again, those first 72 hours can be extremely critical and can prolong recovery if we get into an excitotoxic response. And again, this presents a vulnerability that's also linked to symptoms, which is also linked to activity. So again, decreased activity can increase excitotoxicity, which can exacerbate symptoms, particularly those dealing with mood and cognition, less so with memory. But one of the long-term sequelae of post-concussion syndrome is impaired memory, particularly short-term memory. So what is it that my technology, qEEG, actually measures? Well, it measures in real time brain electrical activity. Then we take that activity, we compare it to age-matched peers, and then we quantify each of those squiggly lines into a metric. And so I'm going to show you what it is that I mean. So let me change screens here. So somebody tell me, are you able to see the brain electrical activity here on my screen?
Yes.
Yes.
Yep.
Okay, I'm going to convert this to raw just so you can see what we look at. So this is what we're looking at, a bunch of squiggly lines. And as we move it back and forth rapidly, we can actually see that there's a couple of lines that don't look like the rest of them. And it's right here in the region of the right central parietal region. And just so happens, this is one of the most famous cases in qEEG literature. This was a gentleman that was struck in the head by a baseball bat. I think we could all agree that would be an insult to the brain. So he was struck in the right central posterior area of the head with a baseball bat, and it produced these excessive slow waves. So we don't want to see excessive slow waves in the brain, and they particularly piled up around the area of the central and parietal regions. So when we move our little cursor over here and we can compare it to the database, we can see it C4, and I'm going to mark it. So C4 and P4, so central and parietal. Those two areas actually have the highest activity that we can see in the screen. And that activity was caused by, that excessive activity was caused by being struck in a baseball bat. So when we want to look at it in 3 dimensions, we can see that same activity translates to right over here. Let me get rid of some of this confusing looking stuff. Turn off the brain berries too. So this is actually where he was struck, in the right central parietal area of the brain. Now, the qEEG is sensitive, but not specific. Well, what do I mean to that? So it's sensitive to changes. So it depicts changes, but it's not specific as to causation. So one of the reasons why we don't use qEEG diagnostically is it's not specific. So what other things could cause something like this big blob of red that we see at the right central parietal regions? So, well, we can have the actual cause in this case, which is a baseball bat to the back of the head, but you could also have it from a motor vehicle accident where the right central parietal region would strike maybe a doorpost or hit a really hard headrest. It could happen in a fall. It could happen from some focal findings like a stroke or a cerebral vascular accident, which is another form of organic head injury. It can happen from a neoplasm, which is a tumor. So there are other causes. And since there are multiple causes, and we can't say this particular excess energy can only be caused by a traumatic brain injury, we say that it is not specific. So how do we use it then if it's not specific? Well, we can use it to detect those functional deficits that I was talking about earlier. So we can look at very specific areas of brain like executive function. So if I switch it to executive function and I just look at those brain regions that are associated with executive function, I can see that there's some fairly significant right hemispheric excesses of electrical activity in the areas of the brain that are associated with head injury. He also had some visual field neglect. So we could look at the visual field and look at visual processing and see that that some of the parts of the brain that are associated with visual processing, which are depicted here, are significantly impacted by that excessive activity. So it helps us to establish what the functional deficits might be. This is looking at the attention network, the dorsal attention network. This guy has terrible problems trying to gain and maintain attention. Here we can look at salience, which is decision-making, planning, and the ability to determine what's important. And again, we notice that those are right-sided effects. So the qEEG can help us to determine what the functional deficits are, though not looking at the brain diagnostically. We can also look at maps that are derived from the brain electrical activity. And these are maps that help us tell us how, whether it's too hot or too cold. So think about Goldilocks, the story. Goldilocks sat down at the table and she tried some porridge. It was too hot, then too cold, and another one just right. So in brain electrical activity mapping, we call these Goldilocks maps. It's either too hot or too cold. So in this delta absolute power that's depicted here, you can see that there's too much energy in the right hemisphere. But you can see in terms of beta, it's a colder color. There's not enough activity. So this is what we mean by too hot, too cold. Otherwise, the black area represents that which is just right. We can also look at some very specific metrics like amplitude asymmetry, which happens to be one of the hallmarks of brain injury. So we can see that the left hemisphere is asymmetrical compared to the right. That's because we have a right-sided injury. We can also look at what's called a discriminant function test. So we can look and discriminate between our guy and the neurotypical population using a discriminant analysis. So this is looking at the population of head injury and the population of neurotypicals. So the neurotypicals is represented by this green bell-shaped curve, and the traumatic brain injury population is represented by the red bell-shaped curve. And so our guy's score is where this black dotted line is, which puts him in the TBI group with a 99.5% probability. So a probability statistic is just that. What's the likelihood of membership in the head injury group, and what's the likelihood that he's not in the head injury group? So it's a 99.5% probability of membership in the TBI group and a 0.5% probability that he's in the normal group or the neurotypical group. And then since he's determined to be probably in the TBI mild TBI population, we estimate the range of severity is in the moderate end of severity. So again, this doesn't tell us that the person has a TBI. It tells us what the probability that he fits within the membership of a given group. Now, 99.5% probability is pretty good odds. All of you would go to Vegas and bet till your hands bleed if you had a 99.5% probability of winning any given game. So it's a pretty high probability, but there's still this very small probability that it's not, if that makes any sense at all. Okay, so that's how we use the qEEG. The other thing that we do is look at functional connectivity within a given group. So let's turn that off. Let's turn this back on. Let's turn our brain berries on, and then let's look at connectivity. So one of the things that we know in head injured individuals, that the brain does not share information appropriately. There tends to be hyper coherence or over connectedness. And again, it's because there's a weak region of the brain that needs help. The weak system is almost always the one that the blue lines are pointing to, and the red lines are almost always the ones that are helper systems. The other dead giveaway is what we call information flow, which is the amount of information that's flowing in the impaired network. So again, he was hurt back here. There's not enough information flowing there. There's a compensatory amount of information that's flowing frontally to try to make up for that deficit. And this is, again, how we tend to look at those head injuries. So let's jump back into the show. All right. So what we're using, again, is the qEEG to give us an adjunct to be able not to diagnose, but to assess the extent and nature of the injury. So the diagnosis has already been made by competent medical authority, usually an ED, in an emergency department, a physician, PA, or nurse practitioner, or has been made by primary care physician. Less often, we don't see mild traumatic brain injury or post-concussion injuries from neurologists, but there are neurological practices that specialize in concussions. And so we do frequently get them from those neurologists. But generally, your TBIs of the mild to moderate severity range are going to be diagnosed by emergency department and primary care physicians. So we're going to use qEEG not to make a diagnosis. We've already got that. We're going to be using it to make an assessment as to functional deficits. We're also going to be using other things like neurocognitive tests, particularly computerized neurocognitive tests like CNS vital signs or brain gauge or Craos or one of those other computerized tests, because they're better at picking up, computerized tests are better at picking up the minute changes in timing that the brain suffers as a result of a TBI. So those that are administered by paper and pencil, those that are administered using a stopwatch and a human in the loop are not going to be as sensitive as the computer is. So you use computerized neurocognitive tests, and then we're generally going to use ocular motor tracking tests. We like right eye because it gives us all that we need. It's got an FDA standard test. It also allows us to give immediate remediation eye tracking exercise to send home with the patient immediately after their test. So as soon as their test is over, they've already got eye tracking exercises that they can do at home. And it helps us to, again, provide that convergent validity between the qEEG, the emergency department records, the statements of the subjective statements of the patient and his contemporaries that can tell us, how impaired they are, the neurocognitive test that shows us levels of impairment in specific domains of impairment, and then the eye tracking. So again, this gives us some really good data that converges to tells us, yes, they've got executive deficits. Yes, they have deficits in salience process. Yes, they've got some default mode stuff. It's going to affect sleep. It's going to affect attention. It's going to affect the ability to tolerate, white light environment. And those things are going to lead us into our treatment decisions. We want to make sure that we're using standardized acquisition protocols, that we collect the data the same way, that we use the same measurement statistics, that we're using the discriminant scores, that we're following good recording hygiene when it comes to the CNS vital signs, the right eye, and the qEEG, so that we don't have any artificial artifices that are introduced into the record as a consequence of poor hygiene. So we'll make sure you're doing everything we can to collect good quality data from which to make our decisions. Again, whenever we're using qEEG in particular, we want to make sure that we're using it in a way that's supportive to the client's case, but not try to use it in such a way that would make any deciders of fact think that we used it diagnostically. And again, it's the objective bridge between subjective symptoms and the other underlying neurophysiology, pathophysiology that's driving everything. So again, this funnel of convergent validity helps us to get the opinions, the competent medical authorities' opinions, turn them into an actionable plan. So that's going to begin at the bottom with that good H&P that's done by the clinician and a detailed, description of the proposed mechanism of the injury, and then the sequelae that fall from that. Then our neurocognitive testing, the qEEG neurophysiology, then this multimodal assessment that we talked about earlier. And that may involve sleep studies later, because many people, after taking an insult, will have a significant amount of sleep alterations, maybe even some circadian sleep disruptions as a result of their injury. And believe it or not, even a circadian sleep disorder arising as a consequence of post-concussion syndrome is still going to be categorized as a mild TBI. Then we take all these data points and synthesize them. If you use our services, we synthesize them into a comprehensive report where we begin with the emergency department, competent medical authorities, H&P, their observations of what they saw, in close proximity to the injury. And then all of our assessment tools are then brought together to bear to prepare that convergently valid report, along with recommendations as how to best remediate that, both from our own clinical experience and the literature. And we tend to be a little bit further, leaning forward on remediation, because just in the last couple of years, the literature hasn't caught up to where we are clinically in terms of mild hyperbaric oxygen therapy, acoustic neuromodulation, pulsed electromagnetic fields, transcranial alternating current, direct current, and photobiomodulation in combination with mild hyperbaric. Even though there's a long literature in neurofeedback, and in some states like Texas, it's actually mandated by the insurance laws that it be covered, there still are very few people who are able to avail themselves of neurofeedback, even though it's shown to be one of the best at remediating head injuries and getting returned to former levels of neurocognitive function. So all of those are going to be spelled out in our detailed report and our recommendations for your plan of care. One of the things that we want to make sure is that we have a pretest protocol that helps us to ensure that during the collection we get good data. So we'll make sure that we've got a good handle on medications, because medications can produce artifacts in the EEG, particularly if they're stacked. So if you've got antidepressant, an anxiolytic, the sleep medication, a rescue medication for panic, you've got, a GLP-1 inhibitor, you've got things for hypertension. When you have polypharmacy involved, it can really interfere with our ability to get good quality data. So we want to make sure that we are only on the medications that are absolutely necessary. And even we're not going to tell people to quit taking their meds, but we may tell you in our report that we can't give you the certain kinds of findings we'd like to be able to give you, because polypharmacy may have contributed to what we're seeing in the EEG. So sleep quantity and quality for at least 48 hours. Sometimes we look at the last week, particularly if we're going to do the Pittsburgh Sleep Quality Index. We're going to look at sleep for a week and see if there are any perturbations to sleep that might actually be driving their symptoms. Because, if you go without sleep for 2 or 3 days, it's going to affect your executive function. Matter of fact, two days of insufficient sleep is the equivalent of 3 beers before driving. So, it can affect you pretty significantly in terms of motor speed, reaction time, executive function, and reasoning. So pretty significant impacts. Nicotine can actually mask cognitive performance. So nicotine, we actually use nicotine patches as part of our TBI recovery program. because nicotine can improve brain function, because the brain is particularly sensitive to the presence of nicotine. So we'll use 3.5 to 7 milligram nicotine patches for the first 2 to 3 weeks. And we actually get almost as much cognitive benefit from that as any other intervention. Now, it's not a good long-term solution, but in the short term, it can be particularly helpful, particularly for folks who can't take a week off and have to go back to their jobs and have to be able to function at work. Current pain levels again, using pain scales are important. Environment that we're giving the test in has got to be optimized. Sometimes we have to go to the patient's home, and so it's good not to have, fluffy and spot, around the patient while they're trying to collect the data or to give tests, or having kids crawling on them while they're trying to give tests. So we do need to clean up the testing environment, because that can influence the outcome. During the acquisition, we want to observe good hygiene, and those things are listed there at point 2. And then our post-processing, we want to make sure that we're following our standard protocols for that. And again, those are highlighted here, and I don't want to go into any detail. You can read those things. Well, I'll give you these case examples. In the first case, we have a 42-year-old construction manager that has persistent headaches, light sensitivity, so light reactivity, difficulty with multitasking 3 months after they had their injury. And again, that's typically when we get to see people. We don't typically get to see folks, within 72 hours of the injury. We normally are getting them because the emergency department or somebody, oh, those headaches, that'll go away. Oh, don't worry about it. You'll be fine. Just rest. In a few days, you'll be able to go back to work. There's really nothing we can do for a concussion but work. By the way, if I leave you with anything during this presentation, know this: there's tons you can do for concussions immediately, 2 weeks later, a month later, 3 months later, 3 years later. So it is not true that there's nothing that we can do to remediate concussions. That's a bald-faced lie, and whatever else you want to call it. It's just not true. So when we looked at the qEEG, this particular individual had frontotemporal hypercoherence. That's what I just showed you. That's actually this guy we're talking about. And he had reduced alpha variability. There's pretty much a sameness to alpha at every channels. So you don't need to understand alpha, beta, theta, and all this stuff, but you do need to understand that anytime a biorhythm gets flattened, that it looks the same everywhere, that's no bueno. So where you look at a heart rate for you nurses, you don't want to see a flat QRS, because that means your patient has expired. So you don't want to see any flat lines in the EEG either. We want to see some flexible variability in there. And so that alpha flattening was actually evidence of the injury. So whenever we did our intervention, which was neurofeedback, mild hyperbaric oxygen therapy for 40 sessions and 30 sessions of neurofeedback, there was a 40% reduction in the headache frequency, severity, and duration. And he was able to return to modified duty at 4 months, and that at 6 months, he was back to full duty. So there was a gradual return to full work, but it was based on the recovery of the injury. We had a 28-year-old elementary teacher with cognitive fatigue, word finding difficulties, and sleep disruptions that was 5 months post motor vehicle accident. And this is actually the more typical presentation. Somewhere between 3 to 6 months after a motor vehicle accident, this worsening of symptoms. And everybody says, well, if it's just a concussion, it'll eventually get better. No, that's not true. In many instances, it doesn't get any better. And in some significant part of the population, somewhere between 30 and 40%, the symptoms actually get worse. Well, why do they get worse if the insult occurred that long ago? Well, they get worse because the brain has got to reallocate resources, and eventually it just runs out of resources. It is a resource-limited organ. And so if you burn up all your glutamate, or if you burn up all your serotonin, norepinephrine, epinephrine, phenylethylamine, in particular PEA, phenylethylamine, you tend to get these cognitive, gradually worsening symptoms. So the qEEG revealed that we had this frontal asymmetry. The left-hand alpha was greater than right, and some excessive theta relative power. along the midline. The midline structure is called the anterior cingulate gyrus, the ACGY. And whenever the anterior cingulate gets stuck in any wave state, whether it's delta, theta, alpha, whatever, when it gets stuck, you get stuck. You have problems shifting between states of arousal. And so if it's high frequency stuckness, you tend to bounce around like a BB in the back of a boxcar. You're just all over the place. And if you get stuck in lower frequency, it's like having your brain in oatmeal. You just can't seem to get into a higher state of arousal. So it doesn't matter which frequency you get stuck in, stuck is not a good thing. The brain needs to be able to flexibly move between states of arousal. And an arousal state can be sleep, drowsiness, alert, anxious. Those all represent different states of cortical arousal. So we're talking about the cortex is aroused. We're not talking about sexual arousal. So whenever we're talking about the arousal of the cortex, being stuck in any one arousal state is not a good thing. So we changed sleep hygiene. We took away blue light. We got the cell phone out of the bedroom. We got all technology out of the bedroom. We got her wearing a sleep mask because she was sleeping under a ceiling fan, and under a ceiling fan, the light photons are still being chopped up by the ceiling fan blades unless you have a sleep mask on. Put earphones in her, and pretty quickly we're able to get her back. We also did some vestibular therapy. We use a thing in our practice called theta chamber to help reset the vestibular nerve. And then she was able to go back to the classroom after 6 weeks of targeted intervention. I didn't put it in there. We also did high dose omega-3s. We did a supplement from Thorne Labs called Brain Factors, and we gave her 10 milligrams of creatine twice a day for a total of 20 milligrams. That's a lot, but it's what it took to get her back going. So again, we don't claim we diagnose with qEEG. We again assess the extent and nature. We can't definitively determine causation. Again, we're saying that qEEG is very sensitive, but it's not specific to any one given etiological cause. Now, because the injury happened, and we can see where the injury happened, and we can map it, we can use these probability statistics to say it's more likely than not, but we can't definitively say this is why this happens. It does give us an objective neurophysiological pattern that helps us inform what we're going to do clinically. It does give us reproducible findings, meaning across multiple subjects, these findings are reproducible. And it gives us, again, evidence-based recommendations that we can target specifically what it is that we're wanting to do with our patient. And again, this approach, we've been doing this now for going on 20 years in my practice, has yielded some pretty significant results. We tend to get everybody else's problems with post-concussion recovery. So when somebody hadn't recovered well and the neurologist can't really figure out what's going on, all the neuroimaging is negative, the labs are largely negative, they send them to us to figure out what's going on and to treat them. So we've developed a niche in our field in TBI recovery. And again, it's because of this approach we take to assessment. Again, the old adage, if all you have is a hammer, everything looks like a nail. We've got a full toolbox of assessment techniques, and we don't just rely on neuroimaging. So again, what do we do? Over the next 12 to 24 months in the recovery, again, we want to standardize exercise protocols. We find that inactivity can exacerbate symptoms. So if you have somebody who was a couch potato before, you're going to have to encourage them to get off the couch as a way to not only recover from their injuries, but also to maintain a healthy lifestyle going forward. We want to use multimodal biomarkers. And again, coming up in this new head injury assessment protocol that's coming in 1 January called CGIM, we're going to be looking at those multimodal biomarkers and advanced EEG metrics to be able to stage and accurately assess where a person is in the head injury sequelae. And then we want to standardize our care pathways. We want to use evidence-based stepwise protocols to be able to get people from acute to post-acute to hopefully subacute or into the chronic phase, those things that are best done. So for example, hyperbaric oxygen and ocular motor interventions are best done as soon after the injury as possible. Neurofeedback generally does better within weeks to months or even years after it. So it can be a later intervention. Photobiomodulation can be done at any time. It can be both used as a recovery tool and as a long-term maintenance tool, which is how we use it, both with neurodegenerative disorders as well as neurodevelopmental disorders and TBIs. We use a lot of photobiomodulation. And the evidence that's coming out of our working group at Harvard, I'm part of the Massachusetts General and Harvard Working Group on clinical photobiomodulation, is nothing short of amazing. We're seeing people with mild cognitive impairment, which is the early stage of Alzheimer's, do photobiomodulation, and they're no longer diagnosable in 90 days. I mean, that's amazing. So we're not just arresting the progress of the disease, we're reversing it using photobiomodulation. We're seeing the same thing with TBI. So again, we want to be on the cutting edge of interventions. We don't want to be dealing with research articles from 10, 15, 20 years ago. We want to be doing what's in the state of the art. And unfortunately, research articles are not keeping pace with clinical research or clinical developments. Again, standard of care, initial response, relative rest, not strict bed rest. You may want to reduce exposure to light and loud sounds just to give the brain a little bit of time to recover, but gradually we want to reintroduce some light loads. We want to increase hydration. Using electrolytes is extremely critical in this early period. And then again, we want to pause activity if we start to see, some worsening of symptoms. There are some red flags: worsening headaches, focal neurological signs, obviously seizures, multiple episodes of nausea and vomiting, or if you get a significant deterioration in mental status. So something that's totally developmentally inappropriate, loss of language, the inability to comprehend verbal cues, finding people in the fetal position on the floor of the bathroom naked, that's a pretty good red flag warning. So, and in those cases, you return to the emergency department and make sure that you talk about, insults to the head. Again, I've already talked around this a little while, but here's a slide that actually says why, rest and weight can harm. It's important that you know this, again, because if you see people recommending excessive rest and not a gradual return to activity over the 24 to 72 hour period following the insult, again, that's a problem. Now, I will say the other problem is we almost always get these folks well after that relative rest period. So one of the things we want to assess for is, what did you do immediately after your injury? Did you go to bed? Did you call in sick from work for a week? Because we want to really know, what did you do? Because some of what they may have done may have led to these worsening of symptoms or the lengthening of symptom expression. Again, what we want to talk about here is that we use TBI not only in the assessment, but we reassess in our clinic, for example, every 5 sessions of neurofeedback. We do another qEEG to see, is what we measured moving? Is it moving in the right direction? But by measuring it again. So we're always doing successive iterations of measurement. So just like it always gets darker just before the dawn, it almost always gets worse before it gets better. So anytime you challenge the brain to change, just like a 2-year-old, it's going to push back and say no. And so we expect to see some deterioration in the EEG as we progress through training, whether it be from hyperbaric, neurofeedback, not so much from supplements, photobiomodulation. Sometimes you'll see an initial worsening for 2 or 3 EEGs, again, every 5 to 10 sessions of neurofeedback or hyperbaric oxygen therapy, but then you'll see it gradually get better. And then we measure them at 6 months and 12 months post-training or post-treatment, and we'll see even better EEGs. Why? because you pointed the brain in the direction it should go. It knows that it's a more efficient way of doing business. And as a consequence, you'll get a more efficient brain 6 to 12 months later, as the brain is building new connections between neurons, and those new connections result in more efficient brain activity. So again, here's some selective, references for you. There's another paper that came out in May of this year. I don't know if I listed it on this next page. No, I didn't. But that next one is the CBIM. So it's CBI, Charlie Bravo, India -M as in Mike. So CBIM, if you just Google CBIM 2025, it'll lead you to the paper that talks about the new model. The Bible for us in the field of TBI is called the Brain Injury Management. We're in Brain Injury Medicine, 4th edition. So it's Principles in Practice. There's also a Brain Injury Management, which it's also in the 4th edition, which is the clinical guide for remediating head injuries. Both of those texts are compendiums. They're, big old fat things, but those are what we use in our field for assessing, diagnosing, treating traumatic brain injury. And the second one that I talked about, the one has essentially the clinical practice guidelines in them, CPGs, is very germane to what it is that you're doing. It's written for the MDs, DOs, and PhDs who are in the field, both clinically and research, but it's highly accessible for what your uses are and can help you determine whether or not one of the recommended therapies might be better than another based on what the Handbook of Brain Injury Medicine or the Handbook of Clinical Brain Injury Management is saying. I know that I've talked at a warp speed because that's what I do. You'll be able to watch this, the video of this later and slow it down. Even for a Texan, I talk fast. So if you've got any questions at this particular point, I'll hand it back over to the moderator and be happy to do my best to answer those for you.
Fantastic. Thank you so much, Dr. Center, for sharing so much information and insight about TBI diagnostics. And as you mentioned, at this time, we'll shift into our question and answer session. Please be sure to submit your questions using the Q&A feature within the Zoom dashboard. And we would really appreciate it if you could scan the QR code you see on the screen and complete this session survey. You'll want to select the TBI Diagnostics webinar today in the drop-down, and it will take you about 2 minutes to complete our survey. In the meantime, let's take a look at some of the questions submitted for Dr. Center. So we'll start with, is the photobiomodulation study treatment a research program? And is this treatment available at MGH now?
Yes, so there are myriad photobiomodulation studies going on right now, and MGH is doing one. Dr. Paulo Cassano is the PI for those. I believe MGH's programs right now are focused almost solely on neurodegenerative disorders. So they're looking mainly at Alzheimer's and Parkinson's. And the reason is because Alzheimer's and Parkinson's is getting a lot of money from the NIH and NIMH because of the gray wave. I don't know if the gray wave is, but it's people like me that are getting old quick. And so the burden of treatment is going to shift to people that are my age and older. It already has. So it's a problem. And so they're looking for wearable technology or at-home technologies that'll reduce the burden on the system. Photobiomodulation fits within that well because it's a helmet-worn device. It's embedded in a helmet. It looks like a bicycle helmet. And the protocols are very easy to run. You just tap a button on the side of the helmet and it runs the protocol. So there are probably several hundred studies that are underway and another probably 50 or more that have been published. We did a multi-site study a few years ago, Baylor, Scott, and White, did one in conjunction with one of the medical schools. And in 90 days, they looked at 100 patients. We had 6-patient mortality, meaning they for whatever reason dropped out of the study. So 100% of the participants showed clinical improvement in symptoms, and 60% were no longer diagnosable mild cognitive impairment after 90 days. So it's pretty significant, improvement. We see similar things with the TBI population, particularly when we combine it with mild hyperbaric. But you'd have to call MGH and ask them if they're doing TBI, but I know they're doing the other two because I'm with, we do our grand rounds for PBM every Friday, and Paolo has talked about the stuff they're doing. It's a worldwide group. The Photobiomodulation Consortium consists of over 100 clinicians from all over the world, and we meet every Friday during our lunch, not the folks in China or Korea or Thailand's lunch, but our lunch, and we do grand rounds on PBM. So it is an emerging technology that's going to come to the forefront because it's accessible, it's affordable, it has great facility, meaning that almost anybody can do it, and the outcomes are astounding. So
yeah, fantastic. I think we have time for just one more. So is qEEG done in New England, in the New England area?
oh my gosh, yes, everywhere.
Fantastic.
Everywhere. You have qEEG providers all over New England. So yeah, you can probably throw a rock in any direction and hit one. I was just at a conference for qEEG folks up in Niagara Falls this past week, and there were practitioners from all over in New York, New Hampshire, Connecticut, Delaware, New Jersey, and Maine. So you probably would do better finding them looking for neurofeedback, because all neurofeedback practitioners are qEEG practitioners. That's how we do neurofeedback, but they may not list themselves as qEEG providers.
Okay. And I think we might, sorry, just try and squeeze in one more. Do insurance companies cover photomutilation treatment, modulation treatment, sorry?
So they may cover it under durable medical equipment because that's what it is, DME. It's relatively inexpensive. So you can get a helmet made by the company called Neuronic Light, for less than $2,000. And as far as DME goes, it's a game changer. And so even if you can't get it covered, many patients will opt to get it themselves. And of course, if they do, everybody in the house is using it. Yeah, I believe that it's going to be required for coverage in my state because there's people like me that are pushing for it, just like we did for neurofeedback. But that doesn't necessarily mean that if the state insurance code requires it, that the insurance companies will then roll over and start doing it, particularly in states where you have multi-state, out-of-state plans that are anchored in the state other than the one your patient is in. So for example, there are a lot of Blue Cross Blue Shield plans that are anchored in Illinois, but covers people all over the United States. Mm-hmm. So the insurance companies will frequently say, well, we're playing by Illinois rules, not by Texas rules. And so many times patients have a difficulty in getting access to care, even if the state mandates it, because their insurance company may be anchored in another state. That's just a problem that we have with the way insurance policies are written.
No, that's fair. Okay, well, thank you so much, Dr. Sender. And I think that lands us just about on the hour. So we want to thank you all for joining MLCC's third Injury Insight webinar of 2025. A playback of this webinar will be available within 48 to 72 hours. Additionally, we ask that you take the time to complete the webinar survey if you haven't yet. And for those who attended live, please anticipate your certificates of completion within the 48 to 72 hours. And thank you again to Dr. Sender, and we know that our attendees really enjoyed learning from specialists like yourself. And our last plug of the day, Our fourth and final Injury Insight of 2025 will be held on November 19th, PTSD with Dr. Tabitha Majorano. If you haven't yet, please visit our website, medicalandlifecare.com, head over to the webinar dropdown and register for our next session. And with that, we conclude today's webinar. Thank you again for watching. Our hosts, Dr. Center and Cindy, and we look forward to the next session. Thank you so much.
Thank you so much, Dr. Center. Thank you.
Enjoyed it. Thank you.
Bye-bye.